CAPSI podcast series, Conversations on African Philanthropy.
We have just completed the 6th annual Philanthropy Conference here in Victoria Falls. Welcome to yet another episode of our Conversations on African Philanthropy with me, Prof Moyo. I'm the Director of the Center on African Philanthropy and Social Investment at the West Business School. This afternoon, I'm very excited to be joined by two gentlemen, Naggib Chakhane and James Phiri, both from the Virtual Doctors. Thank you for joining us, gentlemen.
Thank you for having us, Peggy.
Thank you for having us.
Thank you so much. We've just come out of this 3-day reflections on philanthropy in Africa, focusing precisely on the next frontiers of African philanthropy. But of course, before that, we had an academic session as well. But I just want to focus on the practical sessions and just ask you, Naggib, maybe start with you. Maybe say more about yourself
Sure.
in terms of the work that you do, but also what is your takeaway from these last 3 days?
Sure. So my name is Naggib Chakhane, as you said, and I was born and bred in Zimbabwe. I spent the large part of my adult life in the UK, where I did most of my professional education. Lived in Switzerland for the last 5 years and now living in Berlin. I work with the Virtual Doctors, which is really a telemedicine charity that's UK and Zambian based. And what brought me here was really to try and connect with other like-minded philanthropists and see where we can form partnerships and collaborations, because we're all sort of doing the same work in a different ways and trying to look for avenues to leverage our commonalities to be able to benefit the people that we're trying to benefit. Your question about what was my key takeaway about the conference, oh my goodness, there are so many of them.
Yeah.
The one that really stood out for me the most was the closing keynote. Was it Jacob?
No, Brian.
Brian.
Yeah.
Oh my goodness, I need to listen to that again.
Yeah.
There was just so much depth, so much meat in that. But the thing that I got away from that, if I was to paraphrase, is that we as Africans need to set the narrative of philanthropy in Africa. That was my key summarized takeaway.
Yeah. And to you, James, again, maybe a bit about yourself, especially for our audience, but also to contextualize, I think, the next part of our discussion, which will be around your role as the CEO of Virtual Doctors. But also to maybe to talk a bit about what your takeaways are. I know, Naggib, this is your second time attending this platform. I would want to come back
Sure.
to talk a bit about what you see as the changes or patterns or trends in this platform. But James, back to you just to hear a bit about yourself and what your takeaway points are.
Thank you. I'm James Phiri. I'm Executive Director for the Virtual Doctors. I too have been, was born in Zambia, then moved to the UK, lived there for 30 years, since more than 30 years now actually. And I had a career in finance, mostly IT organizations. And in one, I was also a Rotarian. In one Rotary meeting, the founder of the Virtual Doctors came to speak to us, and he talked about his impassioned sense of vocation to helping people in rural communities in Zambia, where he had worked for many years in the Ruangwa National Park. And he wanted really to have a mechanism through which clinicians in those rural settings could be linked to doctors to help them diagnose patients.
Yeah.
And just the way he presented that convinced me that I needed to be involved with this. So I became an ambassador for the charity, later on a trustee. I then left the board of trustees, and when Hugh, the founder, then decided to be president of the organization, I was asked to come and lead it. So that's what I'm doing now. But in terms of the takeaways from this wonderful 3 days that I've been here, I think one of them is the fact that we do need to focus on collaboration in Africa if we are going to make a difference, and collaborating in the real sense that does not recognize the borders that sometimes constrain what we do. We are one people. We are trying to do the best that we can for humanity, and we can do that best if we come together, join hands, and really focus on, uplifting others.
And so when I met Naggib last year, it was through a mutual friend. We happened to be with Africa Day in Geneva, and when we started talking, he described this organization, Virtual Doctors, and he spoke highly about you. And at that moment, I immediately said, Naggib, we have this conference coming up. It would be good if you guys could come and present the work that you are talking about, because it sounded like a new cutting-edge, innovative way of dealing with social problems, and in this case, rural communities, and how we can deploy, help, if I can put it that way. So maybe, James, I could probably ask you to talk maybe broadly around exactly what is Virtual Doctors, what is this mission, when was it set up? You already started talking about the founder and all of that, but maybe let's now talk to the details of what your programs are, and maybe some of the successes that you could articulate for now.
Okay. So let's just take you back to the beginning, because I think the genesis of the organization is important. So Hugh Jones was working, as I said, at the Ruangwa National Park, and he was, in the tourism industry. And one day he was driving his Land Rover in gravel road, as we have in many parts of Zambia and Africa in general. And he came across some blood on the road. And to his mind, his first thought was that an animal must have been shot or was injured. And so he followed this trail of blood for a while. And then he came across a man who was on a bicycle, cycling, and in front of the man, on the handlebars and resting back, was a very heavily pregnant lady, and the blood was coming from her. And this man was trying to cycle more than 30 kilometers to get to the nearest health facility, because his clinic could not deal with the problem that she was faced with. He decided to give them a lift in his Land Rover, but unfortunately the lady passed away. And Hugh knew some people who were doctors, and he raised this with them. And what they said was that actually the problem that she had could have been resolved at the clinic had the clinician had the right experience and knowledge of how to deal with it. So what he then started thinking was, how could we prevent this from happening in the future? We can't prevent all deaths, but we can do something to help mitigate unnecessary mortality. And that's where the genesis of the idea of the virtual doctors began. How can we connect doctors to rural clinicians? And over a period of 10 years, through amazing support from friends, other doctors, some IT specialists who then were working with you, they built the first app. And it was really built by a group of volunteers meeting every Tuesday, completely voluntary, and there was a process of talking to clinicians, finding out what works for them, what they need, and the app was built and the pilot was started in Zambia. Fast forward another 10 years, virtual doctors, we had onboarded some 150 clinics onto the service. There were over 100 doctors in the UK who were again volunteering their time to help diagnose patients. And now we've just completed developing a new version of the app, which has been developed by professionals. It is now going to be supported properly. And we have onboarded about 300 clinics in Zambia. We have about 200 doctors who we have onboarded onto the platform, and we're in 21 clinics in Malawi. And we have had consultations of over 17,000 cases to date.
So, and I don't know whether Naggib you want to take this, but in my head, I'm envisioning this thing. So think of me as the layman, a lay person, and I'm envisioning this. So there's a hub somewhere, and a hub in this case. I want to understand the mechanics, but a hub in
Sure.
this case, in my head, it's a building. In that building, there are lots of computers where you actually feed data into to connect whatever clinic in rural areas and all of that, the addresses, maybe the capacities and their problems there. And then there's a doctor maybe somewhere in the UK, or the doctors in Zambia, and the doctors are also linked with the clinic. I'm just trying to understand the mechanics of it.
I like that. I think this is just you just
take him through a case?
painted a picture
Yeah.
of the future for us.
Right.
The truth is that, and I'll hand over to James
Yeah.
for more detail. But the truth is that it is so astoundingly simple. It is
Yeah.
much more simple than that.
Yeah.
I don't want to say we feel like frauds being at a technology conference, because we're not frauds. We're absolutely genuine in what we do. But the simplicity of what we do is just so astounding. It's as simple as an app on a mobile phone, a clinician putting in the key information that a doctor needs to be able to help with the diagnosis. And James can take us through the real absolute mechanics of it. But it's really that simple.
So I'm in a rural clinic. You come to me and you have a rash, let's say, on your skin, a dermatological condition, and I don't have the expertise, or I need reassurance that I'm on the right path. So what I then do is I have the virtual doctor's app on my phone. I can enter some details, not your name, because we're very particular about privacy. So I might enter your age, vitals, HIV status, any medication that you're on. There will then be a section for describing what I'm seeing and what you're presenting in terms of symptoms. And there are 23 specialties within the app. And one of them is dermatology, so I'll select that. To help the doctor who's going to advise me, I can also take a photograph of the rash. Again, we don't have images of people's faces and so on. I can take a photograph of the rash and then I send the case. What the system then does is all the doctors who are in the dermatology specialty, one of them is going to be alerted to the fact that they have a case to review. That doctor then picks it up and might ask some additional questions of me. And then they can also, on the app, they can see what testing facilities are available in my clinic. And they can see what testing and resources are available at my next level facility. What that does is to enable them to tailor their advice and guidance based on the resource constraints that are within my clinic. So the doctor then responds, and then I make the final decision as to how you be treated. If you can be treated on site, then I follow that through. If you still have to be referred, then I will refer you. So that's how simple the process is.
And the part of identifying what resources are immediately available or available at the next level is really, really crucial, because we can't have a doctor in the UK recommending a course of action that's not available to the clinician or to the patient at the subsequent levels of hospital escalation. So that's really an important part of the whole process too.
It is. I mean, they say, how do they say? What is the word that says simplicity is the ultimate complexity?
Oh, absolutely.
Simplicity is ultimate complexity. It sounds simple, but actually the impact that it has is just mind blowing. Because you spoke about so many numbers of clinics that you have imported, so many numbers of doctors that you have also imported, and under normal circumstances, this would not be something possible at all. And so maybe we can talk about, so that's the mechanism, but then there's obviously a financing model around it. And here we are in a conference that has been discussing philanthropy. And before we came here, I was telling you about the number of donors who were in this room. So maybe let's talk a bit about the financing model or the model in general that you are using, because part of it could be a commercial model, another could be a philanthropic model, or a hybrid. So maybe let's talk a bit about that. Maybe Naggib,
sure, absolutely. So if we look to say, if somebody was to say to us as virtual doctors, what is your USP? What is the thing that makes you who you are? you'd probably think as a telemedicine charity, we'd say it's our technology.
Yeah.
Up until very recently, when we redeveloped the technology, it wasn't our technology, because our technology was very basic, to be honest. What we feel is the unique thing, and when we start to measure resources, yes, we'll come and talk about the dollars, pounds side of it, but it's really the hours that our volunteer doctors put in, sitting there, and these are doctors that work in very pressurized environments, but they are willing to volunteer their time to the cause, to our cause, and support that.
Yeah.
So for us, we wouldn't be able to do what we do without that.
Yeah.
The other thing is not just the volunteer, the network of volunteers, the network of volunteers that work around us in different spaces.
Yeah.
So James and I started off as ambassadors for the charity. We would go around doing speeches at Rotary clubs and churches and civic halls, etc., like that, just to raise awareness of what we do and also raise some cash just to support what we do. So from a resource perspective, the thing we're most proud of is our ability to keep key volunteers engaged, right from the board of trustees to our volunteer doctors to the people on the ground. We have a handful of paid staff. When I say a handful of paid staff, James will be able to tell you the exact number, but probably on one hand, maybe two.
Yeah, five.
Yeah.
Five.
Five people in the Zambia office who support the whole service. But to come back to your question about funding, suppose let me address two things that surround that question as well. The first one, because we do get this question a lot, the first point is that we only work under the Memorandum of Understanding with the Ministry of Health.
Okay.
That's quite important.
Yeah.
Also, the data that arises from these cases belongs to the Ministry of Health.
Ministry,
Okay, that's also quite important. The other question that usually comes up is, why are you using UK doctors? We've got doctors. Well, in the UK, they have something like 2.8 doctors or 28 doctors for every 10,000 people.
Yeah.
In Zambia, we have one doctor for every 12,000 people.
Wow.
Look at the last numbers. So, there is a need for additional capacity.
Yeah.
The other reason why we're just using UK doctors is that we understand that how to work with UK doctors, how to validate their credentials, how to check that there are no issues with them. Whereas we don't understand the US market and insurance, for example.
Yeah.
But if the Ministry of Health decided that we could onboard doctors from other countries, then that we could do. And we also are very passionate about making this a local service and embedding it, hopefully within the Ministry of Health, with Zambian doctors, with Malawian doctors, or Ugandan doctors, wherever we might be.
Yeah.
And with that, our funding sources are mostly, we apply to trusts and foundations. We have one of our wonderful trustees who started what he calls a 1,000 club, where he's convinced, business people that he's worked with within his network to commit $1,000 or £1,000 a week for a year for a period of years, and mostly that's where our funding comes from.
Right.
But in terms of, because our costs are supported by this amazing group of doctors who are volunteering their time, we keep our costs quite low. Our costs are mostly the core team of 5 in Zambia. The costs of providing a mobile phone to clinicians. They can't afford smartphones. Not all of them can. So we provide the mobile phone and we provide the data. To enable them to study cases. So if we're looking for funding, it is about expanding from the 300 clinics to more clinics, and there are over 4,000.
I mean, I have so many things to say, man. I have so many things to say. So one of them is the doctors that volunteer their time, and the numbers are also outstanding. Do we have at this point an idea of how much in monetary terms that time that they volunteered already adds up to? Because that's a huge philanthropic donation. So that's the one side of it. So as this thing grows, you have these doctors that are actually volunteering time. if we compute that in monetary terms, what does it look like? Because in other words, that's money that would have been paid directly if they were offering their services from a commercial point of view.
Yeah.
And that can be used to actually approach other donors for matching purposes.
Yes.
Okay.
On the side of the clinicians that you work with in Zambia, what is the relationship with telecommunication companies, for example, who probably could be the ones that are donating the smartphones, the data?
Yes. So that is something that we were having discussions on, actually.
Yeah.
Which is the fact that if we take Zambia and Malawi, for example, we are having to send data
Yeah.
and pay for data for the clinicians. With our old app, it was quite difficult to have that conversation.
Yeah.
But it would be good now to talk to partners and other people who have experience about making the new app, which is much more versatile, to work with it in such a way that we are charged for the data that is used within the app.
Yeah.
Because there could be a lot of waste if you're sending data to a clinician and it just has one complex case,
Yeah.
and then next month you have to top up the data.
Okay. Yeah. Yeah.
So that would be good.
Yeah.
And maybe the service could be 0 rated. I don't
Yeah.
know.
Yeah.
But that's something that would be really useful. And also in the West and other countries, there are lots of phones that are swapped for new models.
Yeah.
Yeah.
We don't need the latest
Yeah.
phone.
Yeah.
We need the
Yeah.
phone that has Android software version 8 and up in order to make this work.
Yeah.
So maybe there are people out there
Yeah.
who could help
Yeah.
us with that.
Definitely the 0 rated. That's something that we would like to push towards, to move towards. That will involve obviously partnerships with large telecoms companies in Zambia and Malawi.
Yeah.
And as we expand further abroad, that is something that we'd love to do. That's important. Yes, yeah. But I like your idea about
Computing,
computing the cost
Yeah.
of the volunteer doctors. I don't think we've done that. We probably have somewhere we have the hours. We can get the hours contributed so far, but we should do that. It's interesting. It's funny you say that, but earlier on today I was actually thinking we need to cost the pizzas. How many pizzas did we buy over
the
that
volunteer.
4 year?
Yeah.
Because there's a bunch of techies to get together and work voluntarily on the app, and we'd supply the pizzas while they did that, and they did that for a good 5 years.
Yeah.
Maybe
with us
even
for
longer.
10 years.
Yeah. So that's it. So we'd like to do that, and I like the idea that maybe we can say to potential donors, this is the investment so far, and let's look at matching.
Yeah.
Because there's definitely skin in the game already, and
Yeah.
I imagine most donors want to see what's your skin in the game.
Yeah.
Yeah.
I mean, the other reason why I'm fascinated by this conversation is that even in this meeting, one of the frontiers is AI, technology, and how it can be utilized to fast track and effectively do the work that you are doing. When I started, I was telling you, I'm imagining this big lab with this computers and all of that.
Yes.
That's the future, actually.
That is the future.
That is the future, actually. So, from what I'm hearing for now is that there's so many possibilities. So, for example, what my own thinking as we are speaking is, I know Rwanda has got this thing now where they are able to transport medication using drones. From one place to the other.
Yeah.
Yes.
And in your case, you could be actually have somebody who is providing right diagnosis, everything to the clinician, but then they don't have the
They don't have the drugs. Yeah.
They don't have the drugs.
Yeah, but we tend to have the drugs that are available in the clinic or on the app.
Yeah.
But one of the things we'd love to do actually, as we look at, this is phase 1 of development of the app, which gives us the same functionality but more agile as we did in the old app. Would like to enhance this as well. For example, if the case response time at the moment is 24 hours.
Yeah.
So if the clinician wants a faster response, how do we make that happen without video capability or without audio capability? So those are some of the features that we would like phase 2 to build into the process. Particularly if a case is being sent from a rural clinic to a hospital in country, and that person has got very limited time. The other thing is that the doctors are now responding using a PC or a computer via the web portal, whereas the clinicians are using mobile phones.
Right.
We did two things in order to minimize cost. One is we did not have the the features that would allow a doctor to respond on their phone. But I think that's something that we need to address.
That is something we need to address.
And secondly, we restricted it only to Android phones.
Yeah.
So
Yeah.
some people are using iOS.
Yeah.
So it's something that
Yeah.
we need to
Yeah.
build in for.
Yeah.
Yeah.
I don't know if this applies, but in the research community, we also work with systems like Corpo Collect, where you can just use an iPad, even if it's not connected to the internet, you collect whatever data that you need. And at the moment when you are connected, it
It
sends
sends.
everything
Yes.
through. I'm just full of ideas. It's like
Yeah, that's one of the features that we did build into the current app, that they could do that.
Yeah,
But
yeah,
it was one of
yeah,
the
yeah.
things that was quite difficult.
Yeah,
Especially when people are within an area where the tower
Yeah.
hasn't got the
Yeah.
right strength,
Yeah.
but when
Yeah.
they go home, they pick
Yeah.
up the tower.
Yeah.
So
Yeah.
now they're able to do that, which is to record the case, and then when it picks
And
up,
then send it later.
just send.
Yeah.
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 But I also want to understand, or maybe even not just about understanding, but to help us think through, but also to help us and the audience understand some of the processes that we have to go through in order to end up having this MOU with the Ministry of Health. It's not as simple. It's not as simple as people might think, that you are there, you then. I know governments are so protective, especially in the area of health, education, etc. So for you to end up there and signing this agreement, you would have to go through several stages. But it also means you would have to be vetted to really be a credible institution and a credible set of individuals to actually do that.
Yeah. Again, I'll just start and hand over to James. As James said, we won't go into any country
Yeah.
unless we have an agreement with the MOU. It just it's a non-starter,
Yeah.
especially when it comes to
Yeah.
health. So Zambia is the first country that we went to for the basis that James has just explained, because that's where the founder, was based. Malawi was our second country, and the way we got into Malawi was quite interesting, because we used to have our board meetings at the Zambia High Commission in London. The Zambian High Commissioner was friends with the Malawian High Commissioner, so often we bump into the Malawian High Commissioner. Then he found out what we did, and he says, "Oh gosh, you've got to come to Malawi, and I'll introduce you to the necessary people and all that kind of stuff." So we thought, "Oh, great, we'll go into Malawi, because we've got introduction to the highest level." We weren't asking to cut any corners, but we had introduction to the right people. How long has it taken us to get an MOU in Malawi?
It took us 3.5 years.
3.5 years. This is with ambassadorial support.
Yeah.
It's I suppose it's a long process, because partly you have to build relationships.
Yeah.
You have to build trust. And also you have to hope that the people that you're engaging with are going to be in those positions long enough for you to complete
The process.
Because sometimes when they move on,
Yeah.
you then have to
The
start
project
again.
is also lost.
And understanding that process is takes some time, and it takes a great deal of patience.
Yeah.
And whilst we can be very frustrated on this side of the table, what you discover when you engage on the other side, it's a bit like, when I was in corporate organizations, when you're sitting there and you've forgotten your password, and the IT department takes a while to give you to reset it, you become so frustrated. But how many times do you actually praise the IT department when there's nothing going on? So sometimes when you understand what's happening on the other side of the table, the government side, and you realize just how many MOUs they have and they're going through, and the process of prioritizing them, it becomes just a challenge of how do you get to the top of the pile. And it's relationship building. It just takes a very long time.
And relationship building is interesting, and you would know this. For us, what we discovered, there's a relationship with the individuals, which you need. When that individual leaves, do we have a strong enough relationship with the office to continue that? And if you don't, you're probably going back to step zero. So we want to build relationships with people, but more importantly, we want to build relationships with the institutions.
And I suppose just to add on to that, as you were talking, it reminded me of what Mama Gracia said, which was that we are a village, and as virtual doctors, we have to come to this with the mindset that we are almost like visitors who are knocking on the door to say, we think we have something that can help with your health strategy in a supportive role. Would you like us to come in? And we can't come in with an arrogant mindset that we
Yeah.
know the answers.
Yeah.
We are requesting permission to
Yeah.
operate,
Yeah.
and that's how we see the MOU as the umbrella which
Yeah.
allows
Yeah.
us
Yeah.
to do that.
We've always been very, very clear about that, and not just because James and I are, are Africans and we, chairman and the CEO, but even before we were in those positions, as an organization, we've always been conscious of the fact that we are guests in the company. We are guests of the Ministry of Health. And yes, we are trying to help them do what they do better, bridge the healthcare inequality gaps.
Yeah.
But ultimately, we are guests. They care about their people more than we do. And how do we partner with them in a relationship that benefits the people the most and allowing us to do what we are good at? And we are extremely good at what we do for the size of our organization. But we are guests, and we are there by invitation or by relationship with the Ministry of Health.
And the ultimate success for us would be the day we say we're onboarding local doctors and the ministry is taking ownership and we can be in a supportive role that can be as involved or uninvolved as they want us to be. That would be the ultimate.
Yeah, in fact, I wanted to say that as much as it sounds, and you said it's actually basic infrastructure, you only have, cost to take care of about 5 people, etc., smartphones. It looked as if, it's something that we can easily manage, but the real test of its sustainability may not even be financial.
Yeah.
But it's more the political side of things and environmental. Environmental in the sense that how long will it last for the next generation and the next generation? And I think that's what we are saying now. If ministries actually end up adopting it and actually making it something that they support, there's political will around it, then that's for me the ultimate test of success.
So for a long time, that has been one of our KPI, not so much KPI, but one of our aspirational goals is that we leave the system in the hands of the local Ministry of Health. That will be a success factor. So working ourselves out of a job, so to speak, is a success factor. The other success factor we have is there's an education element to what we do. We don't just want to help a clinician diagnose a complex case. We want to be able to build their knowledge, to help build their knowledge, and help them form a community of other clinical officers that share knowledge. And we have regular trainings and podcasts and meetings like that. So we want our case numbers to go up because that shows we're having more. But on the other hand, we also want our case numbers to go down because when they go down in an area, it means that the clinicians have got the necessary knowledge that sometimes they don't have to come to us. They are equipped to deal with those complex cases themselves. Now, that would be ideal. Onboarding the local doctors is also really important because right now in our terms, MOU terms, it's 24-hour turnaround. We're not emergency medicine because we have a 24-hour turnaround. Now, you could sometimes get a case answered in a few minutes, and James, you can share the burn one. But that's rare. So most of the times it's within 24 hours. But if we had doctors on the ground that were responding as first responders, then we could actually shorten the time that the clinicians are getting the necessary diagnosis because you don't have to rely on somebody that's miles away sorting it out. So that's kind of where we'd like to get to.
And actually on the point of handing over, I remember one conversation with the senior director in the ministry, and he said, "Oh, this sounds very nice, but what's the catch? We've had lots of organizations that come to us, offer us technology, and then in year 3 they say, okay, now you've got to pay for it." And sometimes selling a free service is just as hard as a commercial. But literally, there is no catch. If tomorrow they come and say, "We are ready, we're going to adopt it, give us the keys," that would be music for our ears.
We'd love that. We'd love that.
I'm laughing because a couple of years back when I was with Trust Africa, we happened to have a windfall, and my director then, Akwasi, says, "Here's some money, I think it was $2 million. Do whatever you want to do with organizations that are in the continent." And obviously, I called my friend Brian. He was with UNDP. Then I said, "Brian, there's money here. Apparently, we can."
You mean you didn't have our number at that time?
No, we didn't have a number. Man. So anyway, I said to Brian, let's think outside the box. So we do a scoping exercise. We identify about 10 groups. And we say, let's call these groups and just offer them each $200,000 and tell them, to do anything that they've always wanted to do, but they did not have the money to do. So we called them, we met them in Johannesburg. One gentleman was representing an organization here from Zambia. He came there, and when he heard that, he said, "What is your agenda for Zambia?"
Wow.
They said, no, it's you use the money the way you want.
Yeah.
What is the cage?
Yeah.
So that's what reminds me
Absolutely.
of that at times, like you're saying, something that might look like is free, there are no strings attached. It's actually at times the most difficult thing to sell because
It
people
is,
already
yeah.
think there's
Yeah.
something.
See, I would
Yeah.
have said I'm going to onboard 150 clinics and support them for the next 2
Yeah,
years.
yeah.
Very,
It's,
very easy answer.
Yeah, but I was also thinking, you see, I also come from a regional integration perspective. I've been doing lots of work with SADC, the African Union. And as you were speaking, I was also thinking about the opportunities that also lie in looking at it from a regional integration perspective. So maybe going through SADC and working with whatever relevant department there to look at countries that might be ready to be onboarded. And then instead of one by one, you have this cluster of countries from a variable geometry perspective
Yeah.
to actually do that. And then
Yeah.
over time, but that's from a regional perspective, way of looking at things.
We absolutely hear that. So up until very recently, in the last month, when we've launched our new app, we didn't have the capability to do that.
Yeah.
One of the things that's required is the segregation of data, and really we can't be having cases from one country
Yeah.
ended up in another
Yeah.
country
Yeah.
unless we have express consent for
Yeah.
that. So we're
Yeah.
very
Yeah.
clear about that.
Yeah.
The people that deal with Malawi deal with Malawi.
Yeah.
We don't
Yeah.
have data being mixed up and stuff. But we now have the capability to do that. And certainly, James, we haven't actually thought about a regional strategy. We've been really looking
Yeah.
at country by country.
Yeah.
But that's something we probably should take to the board and look at.
Yeah.
That would be an interesting,
Yeah.
interesting answer.
Yeah.
But we would need to the connections within
Yeah,
the
yeah.
SADC.
Yeah, yeah.
And I'm
Yeah.
thinking about what you're saying. You're the man to connect us. Oh, you know the man or the lady who can connect us, right?
We could. I mean, this platform, for example.
Exactly.
This platform, for
Exactly.
example, is one platform where you can actually get most of those. For example, we sampled from ECOSOC, which is an AU agency. But I think that is really a detail. But the other thing that I was also hearing you say is there's also a level of the doctors who we can call I don't want to use beneficiary doctors, but the ones, the clinicians who are at the local level. So there's education that you talked about, but also there's probably a whole lot of efficiency that this has contributed to us. So I want to hear your views, whether you have done any evaluations, assessments of that in terms of what the doctors themselves have said this has been the impact of this facility.
You mean the clinicians on the ground?
Yes, the clinicians
Okay.
on the ground. But
Okay.
there's also the communities, the people that themselves actually at the last mile, they're the ones that
Sure.
actually
Yeah.
benefit at most. I mean, the doctors benefit, but
Yeah.
they're still in the chain.
Yeah.
And then you've got the communities themselves. At those two levels.
Yeah.
Okay. So from the volunteer doctors' perspective, they are quite engaged, and also they appreciate the fact that this is an opportunity for them to make a difference
Yeah.
to people, and this is the incredible thing, to people they will never meet
Yeah.
actually.
Yeah.
Yeah.
And it is just an incredible thing for them
Yeah.
to do, and it's what kept me in the organization,
Yeah.
because I was thinking, if somebody wants to do that for people who are so far away, I need to be able to do something to support that.
Yeah.
But we did an M&E study recently, and 92% of the clinicians
Yeah.
said that they found the service invaluable for the cases that they referred.
Yeah.
The last mile thing is something that sometimes we hear back.
Yeah.
For example, just as one example, there was a case where the mother was boiling water. She had a toddler in the hut, and she left the house for a few minutes.
Yeah.
Somehow the toddler had pulled the pot of boiling water and got severely burnt. And miraculously, the clinician did send the case through, and even more miraculously, a doctor answered it almost immediately and asked further questions. But one question that the doctor did ask is, do you have cling film? And I don't know why there was cling film in that clinic that day, but using that cling film to wrap it around the baby is what saved the child.
Yeah.
You know, when the child was transported.
Yeah.
So there are some cases like that that are just moving in terms of outcomes.
Yeah.
But yes, you know, we do have data that confirms the value that the service brings.
Yeah. Yeah.
What we, and that's an example of where, you know, we followed the case and found out that the baby was okay in the end. But usually we don't know because the patient's name isn't in there.
Yeah.
And in those communities, there is no residential address.
Yes,
we don't have
yes,
those.
yes.
So the only person who can give us that information is the clinician.
The clinician.
But we don't know. We usually don't know who the patient is.
Yeah. I'll come back to it. I've some kind of an idea of a question that I want to ask, but I want to go back to the doctors that do voluntary work. All of them are employed.
Yeah.
Absolutely.
So there's something, maybe you've already done it, but there's something called workplace giving or payroll giving. So in this case, the doctor who is doing voluntary time could actually use that as a service that is part of the payroll in the organization that they are based. So it's payroll giving. So normally payroll giving means every month I dedicate a particular amount of my money towards this organization.
Right.
It could be hard cash, but
Or time.
in this case is time.
Yes.
And it's captured as payroll
Right.
giving. So I was just going back to that because I think as I was asking you about whether you have computed the amount of money time into monetary terms.
Yeah.
I was driving towards this payroll giving or workplace giving.
Sure.
Because it's a well established practice, and most institutions actually respect and recognize it because it actually also brings them. It's part of their purpose. It's part of their corporate social responsibility for their employees to actually do that. And at times they can even create time for them to do it while at work.
Yeah.
As part of that.
Yeah.
So that's something that maybe you're already doing, if not to see yourselves entering some advocacy around that.
That's interesting. So certainly within the corporate organizations that both James and I have worked in the past, that is commonplace. We have that. I didn't know, I just still don't know whether that's something that exists within the organizations that the doctors that we use work for. But it's certainly something that's worth looking into. Absolutely. I hadn't actually ever thought about that.
Yeah, it's something that we can inquire on. I think it's certainly something that if we were using doctors in private practice,
that would work.
Look at. Because currently we've confined ourselves to the UK doctors, and quite a lot of them are, working in government institutions and volunteering outside of those.
Outside of that, yes.
Those times, Is there a case study written about virtual doctors?
So at APC 2023 in Sali, Senegal, one of the CAPSI guys, we had a brief conversation. Did he come back to you?
No.
Okay, so I introduced him to James because James is the man to talk about that. So there's certainly somebody who said to me last year, I'm interested in doing a case study, so we should follow that up.
No, definitely, because our students and even the broader community will benefit from this. Because part of what I'm hearing is that this is a huge service that we are giving with so much impact, but at a community level, they may know about you, but you may not have the actual. Because of so many of these complexities, lack of address, confidentiality and stuff, we may not capture the real impact as a result of that. But if we do case studies and we begin to unpack them, disseminate them in very easy, accessible formats in different languages at the community level, then there's now a direct relationship between the virtual doctors as an institution and the communities, which is what I wanted to ask, whether you do outreach activities.
So as you're saying that, one thing I realized that if you go to the average person who benefits from our service, i.e. the patient,
Yeah.
who ultimately, when we look at it, who's our client? Our client is the clinical officer and not the patient.
Yeah.
So I'm assuming that a vast majority of the patients don't even know we exist.
Yeah.
I was actually smiling, James, because I'm thinking the only way they may know that we exist is because during COVID, through some generous benefactor, we've got some wash stations that we were able to get into the various clinics, well, pretty much most of the clinics that we work with, and those, had a virtual doctor's badge on it. Otherwise, they wouldn't know. How would they know? They just go to their clinician. They get told, come back tomorrow, and if it's not an emergency, and they don't know that the virtual doctors have been part of that whole sequence.
The other thing that we'll be doing in September as part of looking at this type of area is we're going to visit some of the clinics that we have been supporting. And what we're also doing as part of that is doing some snake bite training for clinicians, because as a person who's pretty scared of training of snakes, I think it's very important that the snake bite training treatment is.
I think more Africans are scared of snakes.
So we're going to do that, and there might be some other programs that the doctors are going to enact. So we're now going back to the ministry and saying we want to do these capacity building and training programs, and and that will be the first time that we've actually gone out into the field with training in mind, other than training on how to use the app. So we're looking at working with other partners on that. And we're also working with a partner, for example, out of the University of St. Andrews. They have developed an amazing product which you can attach to a phone. It's called ArcLight. And then the clinician can take a retinal photograph of the eye, and an ophthalmologist can do wonders with that image. So we're looking at how we can, enhance the delivery of ophthalmological services within clinics as well, which would be quite revolutionary for somebody who's got glasses.
But that's wild, because there's just so many opportunities. I mean, I keep going back to the AI conversation yesterday, but also the presentation that you were in. That we are facilitating. I joined briefly.
Yes.
I keep thinking about all these possibilities going forward, especially with new technologies, etc. So what's your take on AI, virtual doctors, philanthropy, so that we try to then maybe get to the close of this conversation?
I think if you asked various people that work with us that question, you probably get lots of very different answers. In our current context, and maybe this is a great having this conversation with you, because what you're doing is we become accustomed to a certain way of thinking, because we are confined by what we know. And so our decisions and our stuff are based on what we know and what our experience is. So when you throw out stuff like that, you think, oh my goodness, why didn't we think of that? I probably, in my current view, and maybe James will have a different view, I could see AI working in a triage capacity, and then deciding, there are some frequently asked questions, there are some things that are common, that are standard, and so the way we do it now is that as part of our education, the clinician wouldn't necessarily ask the same question twice, and if the clinician, he or she, has learned from that, then as part of the forum, they share their own forum, and so that learning, that teaching is done once, and the learning is done 350 times. But there could be a case where the AI is used in triage and as part of that whole education system. I don't know, James, you're closer to the clinicians than I am.
I think I'd be more concerned about AI if it was the patient directly, because as patients, certainly I know for myself, I'm not very good at revealing, or describing my symptoms to the doctor. So I probably would do the same with AI and get some diagnosis.
Spurious diagnosis.
But within the context of what we're doing, and coming back to operating within the umbrella of what the MOH, Minister of Health strategy, I think if there's co-creation alongside the Ministry's health strategy and what they would want to see out of it, then AI would have a place in that, because we're using country data. It is within the framework of what the government wants to do, and absolutely it can be developed. I think us going out into the wider world, having some version of AI that we think is great and imposing it, I think that wouldn't work. I think that would be the wrong
absolutely. And it goes back to one of the questions in one of the sessions today. Is the problem with AI is that we haven't fed into it. And so therefore the responses that we get from AI are not suited necessarily in our context. So that would be one of the concerns.
And I'm assuming that also takes us into some of the ethics around AI, but also have there been any ethical concerns on your part about the current setup of just the idea of virtual? Has there been anything that concerns? Because I mean, I know when we're doing research, especially where it involves people and health, we have to go through lots and lots of ethics application for us to end up doing that kind of work. So in this case, AI is a huge concern. It can be effective. It's a huge concern for many other reasons. But there's the ethics of it, which I think that's what Ezekiel, the other young guy, was working on. In your case, have there been any, or maybe let me phrase it differently, what are the ethical parameters within which you have built this infrastructure around?
I think there are concerns around, we've had concerns around what data are you collecting? How are you using it? Who has access to that data? And the answer to that is we're not collecting patient identifying data. We're not data mining. We're not selling it. It is just sitting here waiting for the ministry to tell us how they want to use it. We recently had a volunteer doctor who was looking at microbial resistance and how people are, how antibiotics are being described. And we're now going through the process that you just described of going through the ethical approval in Zambia to see if they would allow us to do this research paper so that we can then produce it, give it to the ministry, go through approvals and then publish it. So that's the first time that we're doing that type of work.
Wow. You can tell I can go on and on and on. This is such a I mean, I told you when I met you last year that this thing is so mind-blowing for me. And I wanted to have this opportunity to just have a conversation. And I think we have just scratched the surface, really.
So I walked away from our meeting in Geneva last year thinking, that was interesting. So, because, we've been working on the virtual docs about 8 years. We joined pretty much the same time. We were in the same Rotary meeting that you presented. And I walked away from there thinking, you know what? The only people that, we think that what we do is great, but we never walk away thinking, wow, this is fabulous because of the simplicity of our model. But as you said, the genius is actually in the simplicity. So thank you for reminding us of that. I appreciate that.
And that simplicity, somebody would say, what do you need to onboard a clinic? I need a phone for the clinician. I need data, $2 a month for it, and I can roll it out. So that's that's what we need. And now we've got an app that is supported commercially. We need co-funding for that. But this thing can scale without overhead scaling with it.
I would definitely be working with you outside the podcast to still hear more, but also see,
absolutely, thank you. We'd appreciate
but also see how some of these things that we've just said can be made into reality. So, James Naggib, thank you so much for joining us. I mean, you were saying, are you not tired with this conversation? How can I be tired with this conversation? This was so exciting for me. So thank you so much.
Well, I want to say thank you on behalf of the Virtual Docs, especially for inviting me last year, for inviting us back again this year. So I'm assuming you're going to invite us to Cairo again.
Sure.
But absolutely, it's been a pleasure. And for us, certainly, one of the things that James and I have been keen to do is just to explore collaborations with other organizations in Africa that are maybe not doing exactly the same thing, but doing something where we can add to what they're doing by what we're doing.
No. Also echo the same. Thank you very much for having us. And
Yeah.
yes, let's look at how we can collaborate
Thank you.
and
Thank you.
practice Ubuntu.
Yeah.
Thank you so
Yeah.
much.
Thank you so much.
Thank you, Becky.
Thank you so much. That was James and Naggib, both of the virtual doctors. Thank you for watching. We'll see you next time.
You've been listening to the CAPSI podcast series, Conversations on African Philanthropy.